All right, everyone. Thank you so much for tuning in again for another Joint School Live video. Today, it is fantastic to be joined by Mr. Rahul Patel, a very experienced knee surgeon, who will be taking us through an overview of the sort of things that one might expect after knee replacement surgery. And so thank you to everyone who sent in questions for us to cover today, and sort of topics and suggestions for areas that we'll be digging into and discussing. So thank you very much for that. And of course, you know, for everyone out there who's using the Joint School app and sending in comments and feedback on the articles and the videos and suggestions for things to add, please do keep them coming. We've got an updated version of the app coming, well, quite soon, really. So if you have any ideas and you're playing around with the app and you've got a suggestion for something that you'd like us to add, do let us know, and hopefully we'll get it in with the next release. But without too much further ado, fantastic. Hi, Rahul. Thanks.
Hi, Axel. Thank you for having me.
Oh, absolute pleasure. Absolute pleasure. So before we dive in, do you want to say a few words sort of about, about who you are and what you do?
Yeah, sure. So I'm Rahul Patel, as Axel's already very kindly introduced me. I'm a central London consultant in orthopaedics and trauma. I work at University College Hospital, and my main area of specialist interest is knee surgery. So I cover all aspects of knee surgery, of which knee replacements actually make up a really large proportion. Yeah. We are just coming through, like everyone else in the country, the coronavirus time where it was peaking. And this is a really apt time to talk about knee replacement surgery, because we are starting elective surgery pathways again, albeit very slowly.
Yeah, no, certainly, and I think it's really it's really a key time to talk about, from the patient's point of view. If there was ever a time, I think for years now, there's been this increasing recognition of inviting patients in to become active team members, and sort of encouraging patients to be a bit more empowered and feel that they're able to have some agency and ownership of a treatment pathway. And that, if that was ever the case, then now with COVID and the sort of the uncertainties and extra precautions, it really is a time to sort of know what to expect, to sort of know what's expected of you as a patient, and the things that you can do to help both before and after surgery.
Yeah, I couldn't agree more. I think the joint decision-making process, which if we hadn't emphasized before the coronavirus pandemic, we must emphasize now. It's certainly been my practice for a number of years, really, to involve the patient even more and more and make it their decision that knee replacement surgery is in their best interests. So this really fits nicely with how we're moving forward now with elective surgery like knee replacements or hip replacements.
Yeah, indeed. And I think there's quite a few people out there who've been really keen for us to do some more knee replacement topics. So I think there's been we had a real good number of suggestions and questions coming in for hip replacement interviews, and it just so happened in terms of people's availability that we've had quite a good run of speaking with people who've had experience of hip replacement surgery and a few different points around hip replacement surgery. So we're finally onto the knees. So thank you for that, Rahul.
Thanks, no problem. The coolest joint in the body, so pleasure to talk about it anytime.
Cracking. Well, so perhaps if we begin with a few words, and not diving into it too much, because I think it'd be very easy to do a full hour, if not more, just on surgery in the new circumstances and with COVID-19. But what are the key things that you are highlighting to your patients now in terms of COVID before surgery?
Yeah, so the decision, to be frank, the decision around knee replacement surgery hasn't changed. That doesn't change just because of COVID, but the facts and the informed consent procedure, i.e. what the patient really should know about having knee replacement surgery, because the circumstances have changed a little bit, is really, really important. And that's what we're focusing in on. I have a vast waiting list of patients already. So actually a lot of these patients they and I have already agreed that knee replacement surgery is in their best interests. Yeah. So when I'm recontacting patients now, we're picking up the conversation from there and talking about the pathway about surgery in a given or designated centre, and how we're going to take coronavirus and its associated risks into consideration and reduce them. Mm-hmm. Yeah. So firstly, we need to talk to the patients about what the facts are. And actually, we have very little data to go on at the moment about surgery and coronavirus. Yeah. what data is out there isn't particularly reassuring. Contracting coronavirus in and around surgery yields some complications. And in all essence, it's not a good thing to get coronavirus around surgery if it can at all be prevented. Now, that doesn't mean that if you get coronavirus, you're going to certainly end up on ITU as a ventilated patient. I think that's taking things into the extreme. But if you're already a vulnerable patient by any nature, maybe your age, a comorbidity, or a pre-existing condition, then contracting coronavirus will only increase your risk of developing a coronavirus-related complication a little bit. We do sadly have to talk about the more serious and grave matter of becoming quite unwell and perhaps ending up needing quite an intensive support on intensive care units or through ventilatory support. And we also have to touch on the thorny subject of mortality rates that's been derived from data around the world. But I want, and I stress to everyone that I talk to about this, that this is really evolving data. And of course, as our treatments for treating coronavirus change and our support, treatment and management pathways change, these risks may change dramatically. For the here and now, sadly, it does remain a bit of concern, and therefore we place an absolute paramount interest in keeping that patient coronavirus free before, during, and after surgery. And there's a number of things that we do to ensure that we are meeting that required standard, or that desired standard, really.
And indeed, there's a few of those things that we could dive into quite a lot of detail. But from the patient's point of view, it's about then self-isolating or shielding for a period of time before surgery, and then also perhaps afterwards, and crucially following up and reporting symptoms of living with them and that kind of thing.
So to elaborate on that a little bit, most hospitals in the country now will be split into blue and green zones, or blue and green pathways. I think the only thing for patients to remember is green. Green is good. Green means coronavirus free. And that's how we want every patient to start, in a green pathway, down a green channel. And the way we ensure that is we ask patients to isolate, as you pointed out, self-isolate for 14 days prior to surgery. And I'll come back to that in a minute, because it seems like quite a big undertaking, and I'm not going to belittle it. It is. And then they are tested for coronavirus itself via a swab, i.e. a nose and throat swab, 48 hours before their procedure. And providing that comes back negative, we have the green light once again to go ahead with their surgery. And then once they are out of hospital, providing they've not contracted any symptoms or demonstrated any symptoms, we're asking patients to self-isolate again for a further 7 days to minimize contracting coronavirus at a time when their immune system may be dealing with a whole load of other stresses, those from the surgery itself. And that seems to be a fairly robust pathway in keeping patients safe through the surgical time.
And of course, if anyone out there is watching this video a little bit further down the line, or after it's gone out, it may well be that some of these guidelines and recommendations have changed as our understanding of things evolves and as we learn more. So if you're being advised to do something different, as ever, follow the advice from your surgeon and your clinical team, and that will in all likelihood be the best.
I would say that there may be some very small local differences, and that would have agreed within your hospital trust, with virologists, with infectious diseases experts, with intensive care experts. These things would have been discussed. Having said that, the British Orthopaedic Association and our national associations have guidelines that we're all effectively sticking to, almost to the letter. There will be very small variations, particularly in terms of locations of things, maybe small variations in timings of tests, but effectively that green pathway, a 48-hour swab, proceeding with surgery, and an isolation time either side is pretty much the gold standard now.
Thank you, Rahul. I think that's a really good overview of the current circumstances and what COVID means. So let's move on from COVID and focus on the knee replacement itself and what that will mean. And so when you're speaking with your patients and you're setting the expectations, so if we kind of move through it more or less chronologically, so soon after surgery, or even on the day of surgery and just thereafter, what sort of things, what kind of expectations do you typically set with your patients? And what kind of questions do you get asked about those first hours and that first day?
Well, it's certainly my routine practice to set expectations before the surgeries occurred. I think it's important to let the patient know about what to expect, but also how to optimize their result for them moving forward. And so I often talk about, as you have said, chronologically what's going to happen. And one of the things that I start with, and really I don't want to burden patients with too much information on one go, but certainly on the day of surgery, the main things I'll focus on are pain and its control, and also mobilization.
Yeah.
And this is directly linked to our practice currently in terms of getting patients up and around quickly, because that minimizes complications, i.e. minimizing their time in hospital and minimizing complications that we see with immobility. Yeah. But also from a pain point of view, pain facilitates you mobilizing quickly, or a lack of it, or an absence of it will facilitate you moving quicker. So if we can get pain under control and we can set expectations around pain, the patient knows what's normal pain, what's abnormal pain perhaps, can set their expectations accordingly, although it will still be difficult having never experienced a knee replacement before. And then moving forward to getting moving and getting out of hospital and actually optimizing the outcome of their knee replacement, which we know is intrinsically linked to those two factors.
Yeah.
So if we get pain control right, if we get pain expectation right, we get mobility right, it follows that patients will mobilize easier and be more, if you like, ready to mobilize, eager to mobilize. And if we get that bit right, we know that we're on the better track to a longer term result with a knee replacement.
And I guess to a degree, there's a certain circular aspect there as well, where a degree of the exercises that patients will be recommended and just sort of some gentle movements will in itself also help with swelling and pain.
Absolutely. So one of the paradigms of pain management is that bizarrely, everything else in your body, when it's painful, you try and keep still or you protect. Post knee replacement surgery, that pain is normal, to be expected, difficult to abolish completely, but easier to reduce. But the main thing to understand there is the pain will only go away by moving the joint, by walking on it. It will actually linger for longer if you don't do that. If you stay still in bed, hoping that in a few days' time it might get better, or in a few weeks' time it'll feel better, and you'll save your efforts for later, it's too late.
Yeah.
So sadly, knee replacement is more about gritting your teeth at the beginning when the pain might be a little bit harder to deal with, despite what we're giving you, what doctors and nurses might be giving you. But actually that yields a quicker recovery and also a better recovery. Yeah. We're going to get a more successful knee replacement later on down the line.
Yeah, absolutely. And I think understandably for many patients, that can be a bit of a difficult balance. Yeah. The idea of knowing, expecting some pain, what's good pain, what's bad pain, as some people may refer to it. And certainly, this idea of, no pain, no gain rings true after knee replacement. But of course, at the same time, you want patients to seek help if they are in a lot of pain. And so that can be quite difficult for some people, I think, to know where are the borders between those.
It's very difficult. Pain is very subjective. Pain is very varied.
Yeah. Thankfully,
as clinicians, when we're in hospital, we have certain parameters that we can use to help us decide whether pain is at a level where it's unacceptable, or whether this is pain that we can treat with simple analgesia. So we can look at things like pulse rates and blood pressures and other aspects of the patient itself, including the swelling around the knee, and actually get a picture together which says, actually, this patient's in a lot of pain. We need to change our strategy with pain management. And generally speaking, most patients will be on the same strategy, and that strategy does work for the majority of patients. Yeah. One of the lines that I use that may seem a bit harsh, but I use with patients frequently before surgery is that pain is normal, pain is to be expected, and no matter what medication or drugs we give you, some pain may still be experienced. We can't necessarily get rid of pain completely. So if they keep that in mind and know that the pain is there as a normal experience, it shouldn't stop you from walking, and actually they'll get better. The pain will reduce as they mobilize more. Hopefully that's enough of a stimulus to move patients forward. And I think it's also self-prophesizing in the sense that when they do get going and they do this, if patients do mobilize and experience their pain reducing, they then see the value in what we've been talking about.
Yeah, absolutely. And so, and from your experience, how, in terms of pain, then a little bit on, beyond the first couple of days, how long might one expect to? I know, of course, it'll be different and it'll be subjective, but how long might one expect to need to take some painkillers after a knee replacement?
Well, listen, it can be. I would normally say something like 6 to 8 weeks, but actually it's quite normal for patients to be on some analgesia for up to 3 months,
Right.
3 or 4 months. Certainly after that stage, I would expect painkillers only to be taken as and when, sort of a more sporadic or intermittent basis. But certainly regular painkillers could continue for up to 12 weeks.
Mm-hmm.
And we would hope that the type of painkiller that somebody's taking obviously becomes a gentler and gentler type as time goes on, because the more stronger analgesia is associated with different side effects, constipation, nausea, etc. And so the simpler analgesia is associated with lesser side effects, and hopefully those are the ones that people are taking as time moves on. Certainly in the beginning, however, perfectly valid to take very strong analgesia to help you accomplish your exercise goals and your mobility goals.
Yeah, absolutely. And of course, that the plans will vary somewhat, from person to person and different departments and different hospitals. Mm-hmm. And I guess with this conversation, as with the rest of these Joint School Live videos and with the app itself, it's about setting some goalposts and some expectations, but ultimately it's going to be about your own experience and how you subjectively feel that things are going. And that's where things like the Joint School app, for those who are out there or those who are using other versions of the myrecovery app, the pain score in the app, so scoring pain on a daily basis or some kind of regular basis from 0 to 10, that's your experience of pain from 0 to 10. And then over time, that can then give you a graph of how things are progressing that you can use to find that balance between regular activity but not doing too much, and pain and good pain control over time.
Yes, and that certainly helps someone like me if we have that graphical or data representation of pain, because we don't want to see pain going the other way. No. And if pain is going the other way, believe us, we will treat it properly and review the patient to make sure that there's nothing going wrong, complication-wise. So over time, that first 3 months, we should see pain, as you say, Axel, come down incrementally, but slowly, but come down as mobility improves as well.
And activity goes up kind of in a sort of opposite fashion.
Correct, an inverse relationship.
Indeed. And so we've touched on the painkillers, on the medications, and that movement and activity can in itself help with pain control. So there's much more to pain relief than medication.
Correct.
So ice and elevation. What after a knee replacement? What are your pieces of advice around using ice or cold therapy or cryotherapy, as it's sometimes called, and elevation?
Certainly, both are very useful adjuncts. Mm-hmm. If I was to order them in terms of importance, I would say elevation would come before ice or cryotherapy. And that's my own personal feeling. There's some literature out there, research, which may be a little bit heavy for our layperson, but there's some literature out there that suggests that ice, although may have a somatosensory, i.e. an automatic effect of making the knee feel better, maybe doesn't change your pain requirements grossly, but swelling and pain are certainly improved by elevation. And sometimes telling patients to balance that out can be a little bit tricky because they're not sure how much is too much, how much is too little. Mm-hmm. And so a good rule that I use at the beginning, certainly for the first 2 weeks after surgery, is something called the 15-minute rule, which is my own personal thing. But I just tell patients that they should mobilize, stand, walk around in their crutches for no longer than 15 minutes at a time, mm-hmm. after which they must sit down and elevate the leg mm-hmm. for an equivalent period. Mm-hmm. So you're almost flip-flopping the day, 15 minutes walking, 15 minutes resting, 15 minutes walking, 15 minutes resting. Yeah. And I think for the first 2 weeks, that ensures that the knee isn't put under undue stress, undue strain, undue activity levels, but you are generating some mobility and keeping the joint supple as best you can. Yeah. And then after 2 weeks, that can change. Yeah. And we can start increasing that 15 minutes to 30 minutes or an hour, but adequately resting in between. And elevation can actually be a really useful adjunct, again, for up to 3 months. I've seen patients who benefit from elevation, particularly at the end of the day, for example, mm-hmm. For up to 3 months, because swelling, will occur in a recovering joint, in a healing joint, naturally. Yeah. And as long as that swelling isn't persistent and isn't associated with any other symptoms, such as feeling feverish, etc., yeah. it can be a normal symptom. But as long as that swelling goes away with rest and elevation, and then only comes back with activity, we would see that as almost like a normal evolution of recovery. Okay. Some patients are blessed and don't have as much swelling. Others, I'm afraid, the swelling takes a lot longer to resolve, but eventually does. And I think swelling, the other point I want to make about swelling is it is grossly affected positively, i.e. swelling will reduce grossly by muscle activity. Yeah. So the quicker you get your muscles going, the quicker you're doing these exercises, the better effect that will have on your knee overall in terms of reducing swelling and pain.
So again, there should be another graph there, I guess, where sort of gradually increasing activity should over time gradually reduce swelling. When you say, swelling persisting for a bit longer, or what's the sort of, again, of course, it's difficult to say, but how long is long in terms of swelling?
I think gross swelling that persists for 48 hours, 72 hours, 2 to 3 days, basically, without much resolution, is probably one that you should bring to the attention of your surgeon. I think in the first couple of weeks, it's probably normal just for the knee to be swollen all the time. And then when we start to see the swelling come down, if swelling returns then and sticks around for 2 or 3 days, even though you've elevated it, iced it, etc., then I think that can cause some problems.
Oh,
sorry, I've got an automatic light in my room.
Okay. That's
back on.
It's almost like some kind of nightclub effect you got going. Well, so we're coming back quite a lot to movement and also elevation. Now, I know there's a particular thing after knee replacement in terms of trying to get the legs straight and not resting with a sort of a pillow behind the knee. Can you tell us a little bit more about that?
Absolutely. One of the key motions, or if you like, positions to achieve early is getting fully extended or fully straight. And the reason we really harp on about that and focus on it is because if you do put a pillow under the knee, for example, the knee won't be allowed to straighten fully, but it's comfortable. So let's say you persist with that for a number of weeks, and then someone brings it to your attention that actually you should focus on it. About 4 to 6 weeks after surgery, trying to get the knee straight is a lot harder. Some scar tissue has set in, some healing processes have set in, and the knee just does not extend fully. You might be sitting there on the other side of this saying, well, what does it matter if my knee's missing a few degrees of extension? Well, actually, it's really important for muscle activation, particularly the quadriceps muscle, the big muscle at the front of your thigh. You cannot activate that fully and strongly without full extension of the knee. You cannot build it up without having full extension of the knee. And actually, a lot of day-to-day movements, including walking, need you to be able to fully extend. If you don't, your whole walking pattern becomes more inefficient. You will fatigue quicker. And so not able to straighten the knee fully actually has a lot of knock-on effects, which can be quite significant. So we do really focus on getting the knee fully straight right from the get-go. And so although everyone thinks bending is quite an important thing, and it is, we're actually very keen for the patient to focus on full extension early. Now, the first thing is putting a pillow under the knee is not a good thing. Put it under your heel. That way there won't be anything under your knee to stop it from coming fully straight. Whilst that swelling is there, as I said, particularly for the first couple of weeks, getting fully straight isn't that easy. And you may not feel that you're ever able to fully getting straight, but pushing down and activating the muscles is absolutely what you should be doing. And then as that swelling diminishes, you will suddenly feel that the knee is locking out, fully straight as you might feel your other knee or when it was pre-arthritic. How it felt when it got fully straight. So that's what we're aiming for, and it can take a number of weeks to achieve, but it must be focused on right from the beginning. It's very hard to jump in 3 or 4 weeks down the line and suddenly try and get it fully straight. It'll take a lot more effort and may not ever go. So we've got to make sure that you get it fully straight.
Yeah, absolutely. And I think people will well be given exercise plans or rehab protocols from your surgeon and with your physiotherapist about some specific exercises that you can do to that, such as putting a pillow under the heel and just sort of resting with it, or even a little bit later down the line, perhaps putting the foot and the heel on a chair and resting with that and sort of gently pushing down on the thigh.
Pushing down, yeah.
But it's all right. So we've highlighted the importance of straightening. You mentioned a bit about how bending is often mentioned as a key goal too. So what are the important points around bending after surgery? How soon should one expect to reach what type of bending? How slow is too slow?
Yeah. So by 6 weeks, I think 90 degrees is a good aim. I think if we set that as our goal with a little bit of variation, so maybe a week or two either side, obviously if you're going to reach it sooner, brilliant, well done you. But I think if we allow up to 8 weeks, maybe 9 weeks for specific circumstances, then 90 degrees is our goal by 6 to 8 weeks, let's say.
Yeah.
There is a sort of a mantra in knee replacement surgery which has stood the test of time, actually, for over 50 years since we've been doing them, which is the stiffer you are pre-surgery, the stiffer you might be post-surgery. That doesn't mean that your ultimate range of motion is going to be compromised, but you might find it harder to get there. And so that's what I mean by taking some factors into consideration for that 6 week time limit. If you've been particularly stiff before surgery and actually found your range of motion quite restricted, then actually after surgery getting to 90 degrees is going to be harder because all your muscles and your tendons and ligaments will have shortened a little bit. Surgery will have upset them, so that's not going to help. And then you're trying to achieve this new sort of length pattern, which takes time and a bit of effort, actually. Yeah. So I think 90 degrees by 6 to 8 weeks is a really good goal to set.
Okay, yeah, thanks for that. I think that's a nice goal to aim for. And so we've touched on straightening, we've touched on bending, we've touched on pain, and elevation, and perhaps also ice to help manage those things. Bruising is something that many people will ask about, and of course, again, that will vary a lot. And so, but what sort of things would you say to your patients to expect in terms of bruising, and what are the sort of warning flags perhaps around bruising after surgery?
Yeah, so it's certainly very common. Bruising occurs with the majority of knee replacements. Yeah. We don't just see it around the knee, by the way. Because of gravity, bruising will track, particularly downwards, so towards your foot and ankle. So seeing bruising around your ankle, seeing swelling around your ankle, in fact, the whole limb might be more swollen than the other side, is all part of this circulatory upset that surgery seems to impart upon the limb. And bruising, for example, is just another manifestation of that. One of the things that we're interested in with bruising, however, is that normally patients after knee replacement surgery are on blood thinners. Mm-hmm. And that is routine around the country. So the type of blood thinner may vary. Maybe an injection, it may be a tablet, but everyone's on a blood thinner for about 2 weeks. And that blood thinner can obviously make bruising a little more easy to occur. Yeah. So there is a balance between really heavy bruising, which is occurring because your blood is just getting a little bit too thin, and bruising that's normal. And that's quite simply something that we just need to keep an eye on. I have to say, 9.5 times out of 10, bruising isn't abnormal. It's normal. It's within normal limits, and it's not because of any abnormal blood thinning. But if you're someone that has a bleeding disorder or a blood clotting problem from previous, which is pre-existing, then we need to be a little bit more careful about how we balance your blood thinners. But that should be something that is taken care of pre-surgery and discussed with you in terms of the strategy there.
Yeah, absolutely. And of course, the reason for the blood thinning, as many people will be aware already, is to reduce the risk of blood clots. And again, that's something that may vary. It may be that there are pre-existing conditions, and there may also be slight variations in the medications used and so on from department to department, surgeon to surgeon, and so on. So you will be given a plan for that. Correct. And the other thing that you may well be given as well is the TED stockings or compression stockings. And I know we've had quite a few questions. They can be quite a nuisance, difficult to put on. And I think when people start Googling and looking online and so on, they might find different time periods for how long they should be worn. So what do you say to your patients about the stockings?
So it's an interesting point, this, because those stockings are coming under review now as part of the wider prevention programs for thromboembolic problems, so clots, as you mentioned. And we've long stood by TED stockings as being one of the staple interventions that we can use to prevent DVTs and pulmonary embolisms. And they are a nuisance. And generally, we've asked patients to keep them on for about 6 weeks after surgery, or at least until they're fully mobile. So if you're not fully mobile by 6 weeks, keep them on for longer until you're walking around and your muscles are pumping the blood back up towards your heart, so it's not staying stagnant. Yeah. One of the adjuncts that many hospitals are using now to the TED stocking is, if you like, a calf compression device. Yeah. So literally like a little wrapping around your calves while you're lying in bed, and these will fill up with air intermittently and squeeze your calves for you, thereby giving that muscle action, if you like, in a synthetic way, and trying to encourage the blood to keep moving. Yeah. And actually, some of the evidence that's emerging now is that this may supersede the stocking completely. Okay. Actually, that may be useful whilst in hospital. Mm-hmm. And if the patient is mobile post-hospital and is on a good blood thinning regime, the stockings may not actually be needed to be used for that period or at all. Yeah. I must stress that this is very, very new emerging evidence. Yeah. So many centres and many trusts around the UK will still be using TED stockings probably for about 6 weeks. Yeah. Yeah.
And there around the risk of blood clots, we're encountering another thing where it's beneficial to get moving, to keep moving, little and often, gradually building it up, and just listening to your body and your knee as you go.
Yeah, I mean, the best prevention for blood clots is mobility. Yeah. The more time you spend upright and walking around, within reason, obviously, the less chance you have of developing a clot anywhere.
Yeah. And so on the topic of moving around and getting around, after surgery, crutches, and oh, here we go, it's nightclub time again.
Illuminate me again.
Yeah. So another topic which we've had quite a few questions suggested and sent in is around walking aids or mobility aids after surgery. What to expect? How long for?
Yeah.
What's the concept?
So crutches form the staple, aid for knee replacements. They'll be issued by your hospital. You'll learn to use them with a physiotherapist in hospital, and that includes going up and down stairs, getting in and out of bed, getting on and off the toilet, etc., etc. So safety is one of the paramount factors in terms of discharge from hospital, but also what we concentrate on post-surgery, getting safe on crutches. Yeah. I often tell my patients that it's absolutely normal to use crutches for 6 weeks, and again, I'm using that 1 or 2 week rule on either side. Some patients are a bit quicker and want to get down to one crutch, or maybe their walking stick again after 4 weeks. Some are a bit slower and would like to use the 2 crutches for a bit longer. Again, no hard and fast rules, but if we say that the goal is 90 degrees of flexion by 6 weeks, maybe another goal could be to be reducing your crutches or maybe off crutches by 6 weeks.
Okay.
And that may vary by a week or two, as I say, for some people, because they're a bit slower, that's fine. But let's use that as a goal to aim for. Giving people goals, I think, really helps drive people forward and motivate.
Yeah, absolutely. Okay, and so sort of we're almost moving into sort of the later stages of recovery. Yeah. But before we leave the sort of the earlier the more immediate post-operative phase, I think another topic, and again here there really will be a lot of variation. But so wound management and wound care. Some general points around that in terms of what you would be discussing with your patients before surgery and so on.
Yeah, I mean, we like to leave original dressings on for as long as they can be. So slight spotting of blood on the original dressing is perfectly normal and acceptable. Obviously, if a dressing becomes completely soaked or it loses its adherence, then it needs to be changed. And hopefully we pick a lot of that up in hospital. Mm-hmm. Certainly by the time you leave hospital, one of the criteria I use is that the wound must be controlled in terms of how much it's oozing. Again, a little bit of spotting is acceptable on discharge, i.e. by the time you go home. But anything that's discharging copiously means, I'm afraid, an extended stay in hospital, which may not be because you've slowed down or you haven't achieved your goals with the physio. It may just be that the wound is being troublesome. That's when we look again at things like blood thinners and see if they're being a bit naughty in making the blood a bit thin and maybe reduce those for a bit. Certainly when someone goes home and if they suddenly experience a large gush of fluid from sorry, these lights seem to be going off with more regularity.
I think you need to be more Italian with your arms.
Yeah. Certainly if you experience a big ooze or a big gush of fluid from the wound when you're at home, that is something to bring to somebody's attention almost immediately. Yeah. We would want to see that sooner than, for example, the stitches or the clips are removed within that first 2 week period. Yeah. And then after that 2 week period, when we expect most wounds to be healed, we wouldn't expect there to be any oozing at all. Yeah. I've noticed in a lot of my patients, very, very small areas of the wound might be a bit slower to heal than the majority of it. Mm-hmm. So you might have a very small spot at the bottom, in the middle, or at the top, which just doesn't want to scab over and dry up immediately. That's okay. But someone just needs to keep an eye on it for the type of ooze that's coming out. If there's a little bit of whitish or yellowish discharge, looks a bit like pus, then a simple course of oral antibiotics can actually help that heal up very nicely. Mm-hmm. The majority of patients will heal up within those 2 weeks, and the oozing from the wound, if you like, the bleeding from the wound will just die down very quickly in the first few days.
Okay. And so before we move on past the initial couple of weeks, so in those first few weeks after knee replacement surgery, and of course, again, this will vary and we can't be too specific, but are there a couple of key things that you would want your patients to alert you about or to contact someone about if they occur in those first couple of weeks?
Yeah, absolutely. There are a few different things that we've already touched on actually inadvertently. Yeah. So the first thing is, of course, if you feel unwell. I mean, this is in relation to coronavirus as well. But a fever of any nature after you've left hospital needs to be investigated back in hospital. So don't feel like you can't come back if you've got a fever. It's not normal to have a fever after surgery, particularly after you've left hospital. It may be while you're in hospital to have a slight increase in temperature because the surgery has generated that response. But certainly after you've left, it's not. So that should be a return to hospital, as should what we've just talked about, which is wound discharge. Excessive discharge of either blood or anything else that looks a bit more nasty, straight back to hospital. And sometimes those two can go hand in hand. So you've got a mucky looking wound and you've got a fever. So we need to rule out an infection. Yeah. Then we're talking about clots. So obviously we've got stockings on and we're taking blood thinners. But if despite all of that, you're worried that the calf is red, hot and swollen, for example, or that you may be breathless beyond what you were in hospital, that needs a reinvestigation. And of course, not just from a clot point of view, coronavirus again, coughs and shortness of breaths are symptoms for a contraction of that virus. So again, coming back to hospital.
Yeah.
Slightly removed from those two acute things, which relate to other illnesses and problems, we've got the stiffness of the knee issue, which we touched upon earlier.
Yeah.
The full extension, yeah, you can go away and work on that for 6 weeks. Stiffness in flexion, i.e. not really getting anywhere with your flexion. So you've left hospital, let's say you left hospital with 60, 70, 80 degrees, and the physio said, great, you've only got 10 more degrees to go, I'm sure you'll get there in the next few weeks, fine, or beyond. But actually what you experienced when you went home was that the knee became harder and harder to bend. And in fact, 2 or 3 weeks after you've left hospital, you've only got 30 or 40 degrees of movement. That needs to be brought to the attention of the surgeon sooner rather than later. Some joints just become naturally stiff without any good reason. It's a little bit of the excessive scar tissue being thrown off and your body's healing response. But actually, that won't subside on its own. You can work at it pretty hard, but if you're finding it hard to get past that block, wherever it may be, then bring it to the attention of your surgeon, because certainly getting on top of that stiffness by something called a manipulation, i.e. simply just encouraging your joint to move a bit further, which is a procedure carried out under a very short general anaesthetic, can actually stave that off early on. And we don't want to see that 6 months down the line, because that stiffness is just a lot harder to break down. Yeah. So again, something like the myrecovery app is really, really good for that, because you can monitor range of motion, you can monitor pain scores, you can monitor swelling. And actually for a surgeon to see that tail off is good data-driven evidence that you're struggling and need some attention.
Yeah, absolutely. Yeah, thank you, Rahul, for the shout out for the app there as well. But of course that's some really handy key points. I think the people out there who are getting ready for knee replacement surgery now, who may already be in those early stages of recovery, you may well be given a list of warning signs to look out for from your surgeon, and there may be some slightly different recommendations around that. But I think that's a really good sort of a base plate to move us on into the later stages of recovery. And so you've already mentioned that sort of magic 6 week period, which in orthopedics seems to be some kind of rule. That sort of
it does, doesn't it? Yeah, very arbitrary time. But we're allowing a little bit of a standard deviation there, Axel.
Yeah, of course. But so around that. So I think, really, the questions here are really, we get a lot of questions sent in really about the same sort of things. When can I expect to go back to work? When can I get back to doing what I was doing before? And then also about sports and what activities are sort of too much, that kind of thing. What do you say to your patients around those kind of topics?
So regarding the occupation side of things first, I'm not going to avoid the question, Axel, but that is simply a question to be had on an individual basis. Discussion, to be had on an individual basis with that person's surgeon, because everyone's work is different. Yeah. They need to do at work is different. In fact, it might have changed because of coronavirus. Yeah. So equally, sitting at a desk and typing away at a keyboard, if that's your job, then that's going to be quicker to return to than going onto a construction site. Yeah. So that discussion needs to be had with your surgeon. And certainly I could provide timeframes for those, but then where do we stop? We're going to list of jobs. Yeah. So I think I'll dodge that one a little bit and say, look, have that discussion with your surgeon, probably preoperatively, and see what their expectations are. Yeah. When we're talking about returning to driving, for example, there aren't any hard and fast rules, certainly legally or from the DVLA, about how long you have to wait. Yeah. From my point of view, you have to do a couple of things satisfactorily. One is you have to be able to sit in a car comfortably for an extended period of time. That's sort of, common sense, but it goes without saying. So you need to have a range of motion in that knee. I would say, again, 90 degrees is about right. You then need to be able to operate your feet and your legs for the accelerator, clutch, brake, whatever, safely. And out of those three, it's clearly the emergency brake maneuver that you need to be able to do. So what I often tell patients if they're really stuck is to try and test it out in an empty car park or an open space at an odd time of day. Go with somebody, let them drive you there, and then just see what you're like maneuvering the car around for 10, 15 minutes and performing these emergency procedures. But generally speaking, I think subjectively most people know when driving is going to be okay. They can sit comfortably in their chairs at home. They can get up and out of them easily, because remember, getting out of a car is a bit trickier, twisting and moving. And certainly that range of motion is a prerequisite. So I think unless you've got 90 degrees of motion, I think and your pain is largely under control, then driving should perhaps be avoided until you've reached that level.
Yeah. And indeed also not taking any of the stronger painkillers and things like
yes,
that.
absolutely. So anything that could, impinge on your perception and your ability to operate machinery and cars, etc., we should take into account as to when you're making that decision for yourself. Travel is the other one, isn't it? Travel and when can I go back on a plane? No one's going on a plane very soon anyway. But if you had to get on a plane after a knee replacement, the risk of developing a clot, which is our major one, is roughly about 4 weeks post-surgery. So I don't recommend short-haul flights for 4 weeks and longer-haul flights for about 6 weeks. However, if in an emergency you had to go somewhere because something terrible had happened, then within that 2 weeks, within that 4 weeks, a short-haul flight is perfectly acceptable. If you had to go a further distance and you'd already stopped your blood thinning medications, I would recommend restarting those to cover you for the travel. So that might involve seeing your surgeon and saying, look, I'm only 4 weeks down the line, but I've got to go to the Far East tomorrow because, I've got to go for whatever reason. It may be wise to cover that travel with a anticoagulant of some description.
Yeah.
What was the other return? So return to sports?
Yes. So that's I guess it's slightly different, but that's absolutely my next question. Return to sports, and then of course the follow-on from that is: are there any sports that you disallow?
Yeah, I think I'm going to give the same answer that I gave to the jobs about return to sports. Many people have a specific activity that they like doing, and keep themselves fit with, and I think that's got to be an individually driven answer. So if it's cycling, discuss with your surgeon when, with that particular type of knee replacement, it'd be wise to get back to cycling. So I won't commit myself to a particular time limit with that. But safe to say, exercise bikes within the home are actually really good exercise for the recovery process. And actually, once the wound is healed, i.e. 2 weeks after surgery, I'm quite happy for some of my patients to get on their exercise bikes at home, no resistance, and turn the legs over. Great movement. Really fluid, nice movement, which doesn't upset the knee. And you can actually generate a lot of, movement and actually reduce the stiffness of the knee that way. So exercise bikes at home, slightly going off on a tangent here, but certainly a good thing to do early on as an actual rehabilitation exercise. Other sports, I think we have to discuss those individually.
Yeah.
What sports may not be a good idea with a knee replacement is a really interesting question. So if you'd asked me this question at the beginning of my practice, 12 years ago now as a consultant, I would have probably said, look, running for long distances, running 3 or 4 times a week on a hard surface like a pavement, the knee replacement which wasn't designed for that. So you're going to have to think of swimming and cycling and other ways to keep cardiovascularly fit.
Low impact.
However, playing golf, recreational tennis and skiing, I think those were given. Sadly, as time has gone on, and I say sadly, I've had to operate on patients who are young and had knee replacements, and they have literally just gone against the grain and gone over and done crazy things, and their knees have been fine. So it's not made me revise my statement, because I think overall the replacement is still not designed for that level of athletic activity, particularly the impact of running, particularly on a hard surface, and particularly running that's frequent. So if you used to be someone that ran 5 times a week, I would still say, look, a knee replacement isn't designed for that. But running in a balanced and moderated way is probably still going to be okay. Shorter distances on softer surfaces, combined with other exercises like cycling or swimming to get your cardiovascular fitness. I don't think running is as much of a, if you like, a no-no as it used to be. And certainly in the younger population, who may have a propensity to build their muscles up a little bit better and to get better muscle bulk to protect their knee replacement, getting back to some impact activity is actually more plausible. So I'm not being ageist there by any sense. I'm not saying that your 75-year-old can't get back to running because they just can't build their muscle up enough. What I'm saying is if you get really good muscle strength, and that's evidenced by being able to push your own body weight, for example, on a leg press with one leg, that kind of thing, or go beyond that and actually really build up good muscle and control of the knee, then certainly some impact exercises are actually not a bad idea, actually allowed. Time frames to get back to that sort of thing, how long does it take to get the muscle up? Probably up to 6 months, and your muscles will keep improving for up to 2 years. If you keep putting the effort in, you will see incremental gains, albeit a little bit harder to come by, and albeit a little bit smaller, but you will see them. So persistence for those really dedicated athletes who want to get back to a particular sport, is the key really, and I would promote it now. rather than saying no, absolutely not. But we have to be realistic as well. So we have to balance those two things up.
Yeah, interesting. Very interesting how that's changed. And of course, again, but flagging that it will vary from person to person, and indeed with different implants and so on. So follow the advice from your specific surgeon for more specific timelines and so on. But it's interesting. It sounds like almost there's a bit of a match there to the statement you made about sort of stiffness before surgery, setting an expectation for stiffness after surgery, and perhaps to a degree a level of activity before surgery, or before certainly things deteriorated, to a degree can set expectations for what one may be achieving afterwards.
We can try, and listen, I love it when people achieve more than I expected them to, or even achieve more than they expected to. There's a fascinating debate, isn't there, about how we set expectations and whether we should be, as surgeons, giving patients a realistic picture, which may be the more pessimistic view, and then if they exceed those expectations, then they feel very happy. It's certainly beyond what we were expecting, but actually there's a positive vibe to the whole thing. If I set a goal that was more optimistic and that patient then didn't achieve that, my view is that patient may then be left deflated, feeling slightly disappointed that they went against the grain, didn't live up to my expectations or theirs. A slightly negative vibe. And I think that's a very interesting discussion, because certainly being positive as a surgeon, being optimistic, giving patients the hope is obviously beneficial. Being unrealistic and setting a goal that I simply haven't seen achieved very many times isn't also that helpful. So as a surgeon, I try and set realistic goals, and I try and set them slightly on the optimistic side, but with a sense of realism. And if the patient goes ahead and goes beyond that goal and beats it, brilliant, because I think it's a win-win. I feel great, but the patient, more importantly, feels better that they've achieved something that no one expected them to achieve. Equally, if I set a goal that's realistic, most people will get to it. And if they don't go beyond it, great, but at least they've achieved the goal I set. So the incidence, if you like, or the prevalence of a negative vibe hopefully is kept to a minimum. That is very much my philosophy, I would say. But look, I'm all for people going beyond and above what we as surgeons expect. And like most things in life, the world's your oyster. Go for it. Push yourself hard. Motivation gets you everywhere.
I mean, that sounds like a nice note to take us into perhaps the final piece, if we move on chronologically. So looking forward, and I think this is again a very common question that's been raised a number of times by people using the Joint School app and through the forums, and that's been suggested as something to discuss. How long should one expect a knee replacement to last? And then related to that is the topic of perhaps having a revision knee replacement or needing to have it done again.
Okay, so first question, the longevity of knee replacements has certainly improved. Designs have improved, our techniques have improved, the surgery's improved. So I would be upset if a knee replacement didn't last for about 15 to 20 years now, okay? Wow. And that's taking into account the modern designs and perhaps a little bit of nuance around whether some bone cement was used or not. They're equal now. And those knee replacements that we put in today, 15 to 20 years. However, there's a lot of things that go into how long a knee replacement lasts. There are certain things that are related to complications, such as infections and bad surgery. We have to admit that as surgeons, sometimes knee replacement is done badly. So a complication or bad surgery can definitely shorten your lifetime, your knee replacement's lifetime, I should say. So providing you don't have any of those, the surgery's done well, and you've rehabilitated well, I'd expect that sort of average of 15 to 20 years. If you're on the younger side, i.e., let's say you're in your 40s, maybe your early 50s, which we would still say is the younger side of knee replacement surgery, two things. The first is that younger people are more active generally, and that's not just being ageist, that's data-driven. Young people are active. They may have more active occupations. They generally have, greater social circles. They travel more, etc. They're engaged in more sports. That activity is great, and we promote it, and we love it. It's got many, many benefits. But for the knee, there is a slight preponderance to that activity wearing out, if you like, the component parts a little bit faster. So for younger patients, not only are they going to live longer, meaning that just overall their chances of needing a second surgery are a little bit higher, but they may also be more active. Therefore, the lifetime of that knee replacement might be shortened a little bit. Now, I don't have the exact answers to that. I don't know that 15 to 20 years suddenly becomes 14 or 13 or 12. And in fact, it may not change a great deal. Sorry, let's get the lights back on. It may not change a great deal, but there's just some factors to bear in mind. If you're in your 70s, I would certainly expect that knee replacement to last you your lifetime. And of course, if you became, late 90s, 100, that knee replacement may still be fine. Even though there may be signs on an X-ray or otherwise that some parts are wearing out, it may be perfectly adequate for what you want to do. So the longevity of a knee replacement is often linked to activity and what that patient needs out of their day-to-day life and age. But as a sort of a rule of thumb, if you wanted a sort of a black and white answer, I'd say 15 to 20 years isn't a bad lifetime for a total knee replacement. Partials are very, very different, so we'll make that distinction right now. For total knee replacements, 15 to 20 years, but there are some factors, both on activity and age related, which may influence that.
Okay, yeah, very interesting. And then as a sort of final point, when you're booking someone in for a knee replacement, and you have that conversation about longevity, and then of course if a further operation is needed to correct something, and the knee replacement hasn't working, or sort of it's reaching the end of its lifetime as a well-functioning new knee, what sort of things do you say about the potential for needing that next operation and what that could involve?
Yeah, so I think the first thing to try and reassure patients with is that revision surgery is not uncommon. The more people that have knee replacements, and they're going up, by the way, across the world, the more likely we are to do revision surgeries, because we're getting a whole host of different patients, particularly the younger age groups now, and they are, just because they're sticking around longer, we're going to be doing more revisions. So revision surgery, second time, third time surgeries are not uncommon. They present maybe a slight technical challenge to surgeons, and obviously the second one isn't too much of a challenge, but the third one, the fourth one, they get more and more technically challenging, because what you're working with anatomically, structurally, is damaged slightly, and therefore that can change the type of knee replacement you receive and also what you can expect from that knee replacement. So the first thing I would say is, look, revision surgery isn't a disaster. You will need it perhaps if you were 45 when you had your first knee replacement. By the time you're 65, you might need another procedure. And if you do, we'll deal with it. Do not worry. We'll still give you a good functioning knee, but we'll talk about the restrictions that may occur and the nuances around that second knee when the time comes. So I would certainly act on a more positive basis there and say revision surgery isn't something to be afraid of.
Yeah, it can be part of the normal progression.
Correct. It does lead back to a conversation about whether at 45 they absolutely need the knee replacement now, whether they could buy a few more years. But certainly I just stick to quality of life as being the major determinant about why you need surgery in the first place. Yeah. And then revision surgery, if you read literature, they'll say it has a slightly worse outcome than knee replacements for the first time. But again, sometimes the revision surgery isn't that different from the first time surgery in the sense of the type of implant we're putting in and the state of that knee in terms of the ligaments and the muscles around it. So if you can keep your knee in good shape for those 20 years that you've used your first knee replacement for, it actually stands you in really good stead for the second one. So there's a little bit more motivation there for you. So that if you're on the younger side, there's actually really good evidence to suggest the fitter you are by the time you're 65 with regard to the knee and all its muscles, the better your second time surgery will be.
Okay, good stuff. Well, I mean, we've covered a lot of bases.
Yeah.
That's a nice positive note to round things off. But just to sort of sign off the session, what would you say, and I'm going to put you on the spot here, but what would you say are your top tips for a knee replacement recovery?
Yeah, I mean, it's like those three things that I leave patients with on their day. When I go and see patients in the day, say hi and tell them we're going to take good care of them and everything's going to go well. The three things I leave them with are, sadly, those three things that we talked about at the beginning. The first is pain is normal and to be expected, and no matter what drug I give you, there will be some pain. Take that as not being a bad sign, but as something you have to work with. Number two, that pain goes away quicker if you use and walk on it. And the knee is ready to go, literally from the moment you leave the operating room. So you can't walk on it there because you're not awake enough. But by that evening or the next morning, it is ready to use and ready to weight bear on. And the third thing I tell them is the result of the knee replacement is directly linked to how well those first two things go. So how well they deal with the pain and how quickly they get moving and how diligently they do the exercises, all links in to the more successful knee replacements that people report.
Stuff. Well, fantastic, Rahul. I think that's a really great summary and three key points to sign off with. And thank you so much for joining this long overdue knee replacement special session. And thank you again to everyone watching this and everyone who sent in questions. Please do follow up with any feedback about what we discussed. If there's anything that you thought was unclear or anything that you would like us to dig into, we will certainly be doing a few more sessions and interviews on related topics around knee replacements. We mentioned partial knee replacements. We'll certainly need to do a special session on them and much, much more. So to everyone out there, keep up the good work. Please do keep sending in questions, and we'll see you next time. So thanks very much. Thank you, Rahul.
Thank you. Thank you very much.
Bye-bye.